there is also an audience watching this roundtable, but unfortunately will not be able to take questions from the audience. Instead, we encourage anyone who is watching that does have a comment, that does have a question, to email, and I'm going to give you the email address twice, join the conversation at colorectalcancer.com, and we'll get back to you. So the email again is join the conversation, that's all one word, at colorectalcancer.com, colorectalcancercanada.com, and we'll get back to you. Having said that, I do encourage this team of folks, I feel very honored to be sitting in front of all of them, to ask questions of each other. And while I'll be leading the conversation today, I know that it's a rare opportunity when you have a chance to connect with your colleagues, and this is a chance for you to ask questions of each other as well. So what are we aiming to accomplish with Ready for the Next Round? We'd like to play you a very short video that I think expresses the goals of this initiative very clearly. This is where I say, cue the video. And Maria, I will tell you that there is no sound.
Sorry, you said there's no sound?
There's no sound, no. Even though Maria and I practiced this twice and there was sound.
Sorry, I'll try again.
It's a good thing we're amongst friends. And again, Maria, no sound.
About that.
So you tell me what you'd like to do. If you can fix it easily, otherwise we'll just move along.
Yeah, I'm just gonna try and get it off our YouTube, and if that works, then perfect.
Okay, I think it's worth watching. It's a very dynamic, expressive video of the of what this initiative is about.
Okay, 1 second.
The best chance to beat cancer is to treat the patient when they're at the early stage of disease. You want to get it early and you want to treat it early.
So when COVID hit, cancer screening was interrupted. Because of the interruptions on these screening programs, people will miss their chance for an early diagnosis. They'll find out they have cancer when it's already progressed to a later stage.
Amongst my patients, there have been longer than usual waits to get a diagnosis of cancer, and that means a longer time than usual to get the appropriate evaluation and treatments that they need. It's extremely important for the healthcare system to be ready to deal with the next crisis.
We need to be innovative, collaborative. We will need streamlined solutions with new technologies to be more efficient. Collaboration is going to be key. We all have to work together to get past this and get past the next crisis that's sure to come.
Our preparation needs to begin right now.
Thanks so much, Maria. So I think it's very simply stated that COVID delayed the fight against cancer. And we need to be ready for the next crisis. And being ready is not about bouncing back to the pre-Canadian system that was in place, but evolving into something better, stronger, and more resilient. The goal must be to build a sustainable system that is able to respond to future system shocks, be prepared for longer-term planning, and undertake positive actions, taking into account the benefits and risks to both the general population and patients. So today, colorectal cancer has assembled a very expert and profiled roundtable of physician stakeholders. And I'd like to begin with each of you introducing yourself for a moment. And Brandon, if you don't mind, we'll begin with you.
Sure. My name is Brandon Sheffield, and I am a pathologist or a laboratory physician with the William Osler Health System in Brampton, Ontario. As a pathologist, I'm responsible for diagnostics. So we look at samples that are taken at the time of colonoscopy, and we help determine which one of those represent cancer and help triage patients to the most appropriate next therapy or intervention, whatever that may be. And then I also have a role in molecular diagnostics. So we help do advanced genetic testing to help oncologists decide what the most appropriate systemic therapy would be for colorectal and other cancer patients that are requiring systemic therapies.
Great. Thank you so much, Brandon. Winston, would you like to go next?
Sure. So, hi, everyone. My name is Winston Chung. I'm a medical oncologist at the Tom Baker Cancer Center in Calgary, where I'm also a professor at the university. Academically, I spend a lot of my time looking at real-world data and real-world evidence. And in that vein, our group is also starting to look at the impact of COVID on various cancer outcomes, including colorectal cancer, such as screening, treatment, and survival. So more to come in that area for sure in the coming months.
Thank you so much. Charlene.
Thank you, Anne-Marie. So I am a GI medical oncologist. I'm based out of BC Cancer in Vancouver. I think, most of my practice, as most everyone here who treats GI, is in the realm of colorectal cancer. I think there's a lot of sort of lessons to be learned from COVID and trying to think about how we move forward. So I'm really looking forward to this discussion with this panel, with my colleagues. I also wear a hat as part of the executive for the Canadian Association of Medical Oncology, or CAMO. And through COVID, we sort of took this as an opportunity to sort of survey our membership. So these are medical oncologists, not limited to GI, but just trying to understand, the impact of COVID on practice and how people have perceived that impact on how they deliver cancer care for their patients. So thank you for the invitation, and thanks to Colorectal Cancer Canada for bringing us together to discuss this.
Yeah, well, thank you so much, Charlene, for joining us. Scott, would you like to go next?
Hi, my name's Scott Berry. I'm a GI medical oncologist in Kingston, Ontario. I'm a head of the Department of Oncology here at Queen's. Proud former trainee of Dr. Burks and proud former program director of Dr. Chung. Brandon and Charlene, I didn't have any training relationships with, but I've been happy to work with Charlene on a lot of educational efforts around, especially focused around colorectal cancer and on the impact of COVID on cancer care. So we've been working and thinking a lot about this.
Yeah, thank you so much. As a former Queen's grad, not in the medical program, welcome. And lastly, Ron.
Thanks, Anne-Marie. So I'm Ron Burks, medical oncologist at Mount Sinai Hospital in Toronto, professor of medicine at the University of Toronto, and I'm part of the Division of Medical Oncology across Princess Margaret Mount Sinai Hospital. My primary of interest is colorectal and gastric cancer, but also lung cancer as well, which is, of course, there's lots of stuff been written about COVID and lung cancer. In addition to that, my two areas that I've been involved with recently is one is mentorship. I'm the head of mentorship for the Department of Medical Oncology at the university. And I think we'll probably be touching upon that because there's been a significant impact on COVID and trainees and also the junior staff, let alone the senior staff. And then my other roles, I'm part of the wellness committee within the Division of Medical Oncology. And I think that's an area that's, I suspect we will touch upon significantly because there has been lots and lots written about well-being, resilience, et cetera, et cetera. And I think all of us are feeling this. And I mean, one of the things that we miss on is that, you know, we've been doing Zoom meetings with everybody, but we've not sat around the same table. And I think all of us miss one another and being together and getting together. And, you know, Zoom is great, phones are great, but meeting people in person, you can't replace that.
Thank you so much, Ron, for setting up some really important discussion points as well. Welcome, everyone. And I think the audience would agree we couldn't have asked for 5 better thought leaders to join us today. The conversation will start fairly broadly, and there's been so much literature written, so much literature recently about the impact of COVID on the cancer care system. So we're going to start quite broadly, but we would be remiss if we didn't use the wonderful brains that we have in front of us to get to solutions quickly and the rebuilding of the healthcare system based on the observations, the experiences that all of you have had. So my opening question really is very much related to, in very broad terms, if we could just set the stage on the major impacts on cancer care, particularly if you have something specific related to colorectal cancer care that COVID has impacted on the system. Charlene, perhaps I could start with you.
So, I mean, I think there's obvious clinical impacts, right? And I think for cancer in general, and certainly for colorectal cancer, one of the major impacts of concern were related to both an interruption in screening. So in terms of from preventable colorectal cancers and early detection, so delayed presentations, but even in the presence of symptoms. And we know that this is a reality. I mean, this is in one of our colleagues, Dr. Tefe from Quebec, actually just presented at ESMO, the European Society of Medical Oncology meeting this week, the impact on COVID on colorectal cancer screening rates within Quebec. And one of the takeaways from his presentation, and I think this story can be recapitulated across every province in Canada, is that even as capacity started to build up, with restrictions easing in subsequent waves, there's a huge deficit that has to somehow be addressed. So that's kind of, that's an ongoing issue. So that's live now. And then from a treatment, perspective, I think we all adapted to trying to, use treatments that would reduce visit intensity. And I know my colleagues will talk about that as well. And then I just wanted to add, from a research perspective, I think there was a major impact on clinical trials, the ability to offer patients clinical trials, especially in the early, first wave of COVID. I think in many centers have stabilized their clinical trial activities and adapted protocols, but that also, was a huge challenge.
Can I just ask you, Charlene, before we move to others, would you, across that continuum of prevention, diagnosis, treatment, survivorship, was one more impacted than the other, in your opinion?
Pardon me, was one
more impacted? Was one? Yeah.
Well, I mean, I think it's hard for me to say because what we've experienced so far has been mostly on honestly the treatment scale of things. The consequences of that missed window for screening and those delayed diagnoses, I think that impact is to come. So if you ask me the question today, I would say I'm most concerned about sort of the delayed diagnoses and the impact on treatment. If you ask me later on, I might say, that window where we missed screening had a huge impact on cancers that maybe could have been prevented.
Great, thank you so much. Other thoughts?
Maybe I can go next, and I think Charlene's, as always, started out with some excellent points. I'd say highlighting some of the other things is that with screening, absolutely, we're in a big deficit, but at least we learned. And I think early on in the pandemic, we shut down our screening program in Ontario. I'm not sure about other places, but I think we had enough foresight to say that, as the pandemic continued, and that this looked like a longer, that we had to adapt to a longer period, we did start opening. We have not caught up. There's still a lot to go, but we did see some adaptation. I think that part of the problem now as we emerge and try and catch up with some of the backlogs is that we are now, I think, suffering the effects of ongoing COVID, but also the echoes and post-COVID in that, we're seeing, and Ron alluded to this, burnout. We've seen a lot of nursing resignations. And as we try and ramp things up, get ORs working, reestablish programs in cancer centers, we over the summer had a lot of nursing shortages, and this is in our community, but I think this is a national problem. And I think that as we try and recoup on some of those backlogs that have been created, we're dealing with a very tired and a group of people. We had some time after the fourth wave and during summer to kind of relax and recharge. But we, as we attempt to recover from COVID and the impact, we're dealing with a very with a group where I think wellness will have to be will have to be a priority. I think that as Charlene said, there was opportunities, I think, with COVID to try new models of care. And I think one of the examples, perhaps the silver lining, is that short course radiotherapy, which had not often been as popular modality in Canada as perhaps in Europe, during COVID became a more popular modality because a 25 or a 5+ week course of radiotherapy could be condensed into a week. And I think that perhaps gave us some experience and confidence in dealing with regimens that we didn't have a lot of experience with. So some positive, I think, silver linings. I think the impact on families, we, as we've had to restrict access to hospitals to keep our systems running and our cancer centers running, this has had a huge impact. And I think that even now, we're just starting to be able to let folks in with vaccine mandates and space. We had to, one of our major waiting areas that we use as an overflow to create a safe space for patients, we had to use for vaccines. So I think the impact on patients and families in terms of not being able to have them in the room, we've been creative, and we've been able to have more virtual care where patients and families can attend visits from home. But some of those crucial visits where we had to have during some very sensitive discussions on the phone was obviously quite distressing for our patients and therefore for us. I think the last thing is that I think that one of the in terms of the shortcomings in our healthcare system, disparities, whether it's by race, socioeconomic status, I think that although there's been a general lack of or general decrease in our ability to screen, for instance, I think those have hit some populations harder than others. We've seen COVID hit some population than others. And I think that as we know this existed prior to COVID, but I think that this is going to exacerbate some of the issues that we've seen. And I think coming out of the pandemic, I think we have to be even more aware of disparities in our healthcare system and how to address them.
Yeah. Scott, thank you so much. You've raised, I think, 3 really important things we want to continue to explore. I'd like to go around the group and just get some general comments first, but the concept of disparities, the concept of change in treatment plans, and the idea of burnout. I don't think it's just nurses that are burnt out. I'm suspecting that the oncologist community has its own issues that needs to be dealt with too. So we're going to come back and circle back on some of those things. But Ron, would you like to comment just more broadly on some of the impacts as you've seen them?
Yeah, well, I think Charlene and Scott touched upon the majority. The one thing I haven't heard about too much yet is our surgeons. And I think the impact on our surgeons has been tremendous. I remember our chief of medicine about 2 months ago or 3 months ago said, if you have a chance, hug your surgeon. Because, you know, they've had, I mean, we cut back about 80% on our surgery. So, you know, you have the preventive issue, the screening, and then you have our surgeons who are critical to, you know, to us, you know, in terms of the, you know, primary surgery, the hepatobiliary surgeons. So, you know, surgery has been cut back. They've been, you know, they've had to tell patients, I can't operate right now. And I remember going back to the first wave in March of 2020, we started doing TNT for rectal cancer, not because the literature told us it was the right thing to do. It's because the surgeons couldn't operate and they didn't have time for surgery. So we were doing everything up front to buy time. I had patients, you know, who were getting ready to, you know, getting neoadjuvant chemo for liver cancer, you know, for liver resection. And we had to keep giving them chemo because the surgeons couldn't get OR time because the ORs were closed. Mount Sinai is the high-tech center for a third of the country. And, you know, because our ICU was full of COVID, you know, they couldn't operate, because surgery was not, the surgical units were closed down. We ended up opening the OR became an ICU because they needed overflow. We were taking patients from, you know, William Osler and all these other institutions. And so the high-tech people can't operate without an OR, but they can operate without having access to critical care because all the patients are admitted to the ICU overnight, if not 1 or 2 nights. So there's a domino effect in the whole thing. It's not just one thing, everything is affected. I think we'll get to, you're right on with medical oncology, a medical oncologist's well-being. And even coming out of this, the impact is even greater now because now the surgeons are catching up. Well, who do you think is going to end up getting all those patients? It's medical oncology. And I don't know if we have the resources or the resilience, how much, you know, we have left. We're into a 4th wave now. As Scott alluded to, we had a bit of a break, but this break this year was a heck of a lot shorter than last summer. Last summer, I think we had a good 3-4 months before things started upticking again. This year, it started even before school started. So, you know, and then we also had, you know, a variant that wasn't a variant yet. And I think we all long for the original wild type virus because this is, you know, the Delta is a much more transmissible, aggressive disease. So there's lots of things going on here. And then, you know, I think just the well-being of all our healthcare workers, you know, the nurses, the physiotherapists, everybody, you know, together, the OR nurses, everyone's stressed. And I remember speaking to Erin Kennedy, one of our colorectal surgeons in Cancer Care Ontario, said, well, we can catch up, just work 150%. Well, you know, I think everyone's working 150% already. Mm-hmm. How the surgeons are going to work 150% to catch up on the backlog? And have you asked the anesthetists who are required in the OR, are you going to work 150%? Are you going to work all day Saturday and all day Sunday? So I think there's a lot of issues that, you know, I'm not sure there's a lot of good solutions, but there are things that we need to think about going forward.
Thank you, Ron, for expressing that in such a beautiful way. And I think we should talk about some solutions that perhaps this group has in terms of what I think is one of the most significant gates in the process right now, which is really resource. Brandon, have you got other things that you would like to add to this conversation in terms of just general impacts of COVID?
Sure, I can tell you what it was like from my point of view, which is, I think, considerably different from a lot of the medical oncologists, just because we don't work with patients directly and we are sitting in the laboratory. Colonoscopy screening represents a huge amount of our daily volumes in pathology. And then general surgery specimens represent another huge portion of that. And when GI surgeons and colonoscopists are not working, that has a huge impact for the day-to-day of a pathologist. And an average pathologist will look at they'll see about 30 to 50 patients in a day. And usually no more than 5 of those are complex cancer patients. But when we don't have this large volume of colon cancer screening, when we don't have simpler procedures, things like hernia sac reductions, it really changes the makeup of our work dramatically. And what it did was create a dramatic shift towards more complex cases for our pathologists, because they're not broken up by those more simplistic cases, by those hernia sac reductions, by benign conditions like diverticulitis. Things like even appendicitis was being treated medically and not surgically for quite some time during the pandemic. And then when you think about your colon cancer screening population, the majority of those patients do not have colon cancer. So it's a lot of benign colonic tissue and polyps that we're looking at. So all of a sudden, the pathologists were looking at a very different makeup of tissues, and that contributed largely to a lot of burnout that's still being felt right now amongst the pathology community. Other issues that are kind of from a different angle is that we're responsible for actual COVID testing, and high yield regions would be responsible for close to 500,000 COVID tests over the past 18 months. So we had a role in this, which is quite a bit different from the other clinicians, but then we also had to protect certain aspects of cancer care that were brought under threat due to COVID testing. So for instance, any, all of the neoadjuvant therapy is reliant on molecular testing, yet some of the ingredients to those molecular tests are shared and common to COVID testing. So it became a really big challenge to secure certain pieces of plastic, certain chemicals, certain other things that the COVID testers were really trying to get their hands on, and was never really a challenge for us before. But we had to make sure that our supply of those was tight and reliable so that our oncologists could at least keep offering these makeshift neoadjuvant treatments and other time-saving measures to keep our patients in good shape while the ORs were closed. So,
what an amazing insight. That is certainly not something that has come up in the literature that I've seen. And I wanted to probe in on your concept of makeshift, the way you use the word makeshift. So tell me what that was. It was...
Well, that's the thing, is that throughout all of COVID, that these timelines have always been questionable. Yeah. And when we set up testing centers, they were set up in tents. It's the very idea that they were temporary. And I don't think any of us had any idea that this was going to be a chronic state for the healthcare system. So while a lot of our plans were temporary at the start, we're now starting to think more about the long-term sequelae, and the fact that things like COVID testing and altered management pathways are more permanent, or at least long-term than we first thought.
Thank you. Let me ask you one last question, and I'd like to get Winston's opinion on this. Is we did quite a magnificent patient roundtable yesterday, and at least half of them were early age onset colorectal cancer patients. Can you comment on what what was screening more impacting for somebody who was younger than older? Was there an age factor that you saw as part of your experiences? Was it harder for somebody who was younger to get screened?
I think we'd have to take that on a case-by-case basis, and it really depends on the family history of the individual in question and what age they would have started their screening. And the individual patient, we just need to remind them that screening is a great thing at an epidemiologic level. And no matter what we do with screening, there's always going to be cases of early onset or severe disease that happens in younger people that's unfortunately due to bad luck or reasons that we don't quite understand yet. But on the whole, colon cancer screening is aimed at the majority of patients that develop this disease, which happens in the middle decades of life.
Yeah, very interesting. It was a comment that many of them made, that they felt that the difficulties that they had even achieving a diagnosis and getting treated because they were younger, what was impacted through COVID. Winston, and I'll give you the final comments on the impact.
Sure. I think I echo what others have said already in terms of impact. I think one theme that I may not have heard as explicitly is the impact of COVID on trainees. and the educational experience of a lot of our residents and fellows. In Calgary, at least, when there were significant COVID peaks or waves, we did alter the experiences that residents and fellows can be exposed to in terms of limiting patient contact or interactions. And I think what I'm hearing from them is that I think they're worried about how that has impacted their overall learning experiences. So that part I think does resonate with me a lot, because I supervise a number of trainees. So that's one thing I want to add to the conversation.
Yeah, thank you so much.
Can I just add something to that very, very, very quickly? Because I was speaking to the trainees about this last week, and just two comments I'll make, and to give a good example of this. And one was, one of the trainees was saying that they hadn't met the PGY4, so the first year people coming in, she's a PGY5. It was 3 months before they finally actually met in person, other than by Zoom. And the second thing, which I hadn't even thought about, none of the trainees who started last year and will finish at the end of 2020 or halfway through 2022 will ever have gone to a conference live. And you know that we don't think about that, but the impact of that educational experience, being at ASCO or ESMO or World, Lung, whatever it is, they're not going to ever have experienced. So I think it's something we're going to have to be very cognizant about trainees. They've missed out on basically a very important part of their training. The training, meeting with colleagues, being their fellow colleagues, and going to an educational meeting and presenting live in front with people. So
and to Ron's point, I've heard similar sentiments expressed by junior faculty as well. Those who've just started their position, maybe in the last couple of years. Many of them are also expressing challenges they're facing in terms of networking, because the virtual Zoom platform is still very different than the in-person interaction.
Yeah, and I'd like to keep that conversation going, because I'd like to understand also if particularly some of these trainees have, I'll call it band-aided, some solutions that have allowed them to network in new and fresh ways that are usable going forward. I first want to go back to the issue that Scott raised on disparities in the system, and the idea that is there inequities that have occurred in cancer care in certain populations, certain disparities that you like to highlight or discuss?
I think that in terms of disparities specifically related to COVID, I think we know that COVID has had a much higher impact in terms of incidence, mortality in racialized individuals, people in lower socioeconomic status, Indigenous peoples. I think that in cancer we know there are similar disparities in terms of outcome based on similar on similar basis. I don't think we know whether the impact of COVID on cancer has specific disparities, but I think it's a reasonable extrapolation to think that if there's an impact on treatment, care, screening, that it's going to impact the folks who have a tougher time accessing the system, navigating the system, getting time off, etc. So I think that as we emerge, I just think we have to be mindful of that and think about how. Again, I think it's, we pride ourselves in a universal healthcare system. And I think that, that during COVID, we've been much more fortunate than many other countries in terms of being able to respond. Even in Canada, we've had difficulty responding, stretched things to the edge in Ontario and now Alberta. And seeing that even in a universal healthcare system, some folks just don't have the same ability to access care and have worse outcomes because of that. So I think that it's a reminder. I think that COVID and the things that have happened is a reminder, accentuated those disparities. And I think it's a reminder of one of the major limitations, along with capacity, along with a good public health system, that our ability, even in a universal healthcare system, to address the needs of all people who need care needs to be remembered as we emerge.
Thank you. Beautifully said. Is there any other thoughts on that particular issue?
This is not Canadian specific data, but in my canvas of the literature, because in the past I've done some disparities research, I think there's always been disparities in certain subgroups of the population. So whether it's rural versus urban, immigrants, et cetera. And I think what we're learning is that in the setting of COVID, these existing disparities are just accentuated. They're being potentiated even further. And certainly in Calgary, we see that as well. When we look at some of the COVID cases, it is concentrated in certain areas of the city. So I can only imagine there'll be downstream effects based on those numbers.
Yeah, great. Thank you so much.
So there's two things I guess I'll raise. I think Scott brings up some really, really good points there. And one of the things just thinking about it is, these marginalized people, if you want to say it, or the, individuals who, there are disparities. Often they live in, there's multiple people living in dwellings. So the risk of COVID is going up. There are people who don't have the same access to getting the vaccines that we've always heard about. So the people in the high-end areas of the city get vaccinated and the other groups don't. But they're still getting cancer and are getting therapy and are at higher risk of, developing COVID during all of this. So it's almost like a vicious cycle, even though, as Scott said, I don't think we have specific data. It's probably not very difficult to extrapolate from pre-COVID to COVID and the increased risk of these individuals developing COVID. And then the complications related to that and therapy.
So COVID's really just exacerbated.
Yeah, I think, I think it's not a surprise. This is the pandemic. It has been a stress test, to our healthcare system. And I still think compared to most jurisdictions, we are relatively fortunate in Canada because generally the barriers to access are less, but it certainly, really opened the door in terms of, where we can do better and, look like trying to turn this, challenge into an opportunity, like really identify the gaps that maybe we didn't fully appreciate. And so, I think that's the lens we have to look at it with and say, well, how do we address those inequities? So, within our own practice, I think there has been a lot of conversation in BC about the importance of increasing our nursing capacity. I know, recognizing Scott's point that that's a resource that's highly valued and, they've been put to the limit, but trying to improve our outreach to patients and how we communicate with them. Because, the system will need to be more proactive in trying to help support patients through this. And I think patient groups, honestly, have done really great campaigns to try to raise awareness among patients, like, things like, cancer is still here. I think that was a big message during COVID, where patients were hesitant to seek medical care or had sort of misgivings or not access to good information to be able to make the kinds of informed decisions about their treatment choice. So that outreach, I think, was helpful. That message did resonate with patients. So those kinds of strategies, it's not often, those solutions don't come from within the healthcare system, to be quite honest. They come from the community in which we live, and people recognize the need.
Good. Just Winston, I wanted just to clarify something you said. Is there is literature certainly on disparities across the cancer care ecosystem, but there's no Canadian literature today that you've been able to see?
Yeah, I should clarify. So there are existing literature on disparities in general in oncology and other non-oncology disciplines.
Yes.
But in terms of more recent research looking at disparities and how that's changed in the setting of COVID, I'm not as aware of recent research just yet. As was discussed earlier, it's still relatively, the data, there's always a bit of lag in terms of when they become available. So I would imagine that research in this area is forthcoming. So that's what I would say about that.
Okay. I wanted to bridge into a conversation on alternative treatments that were used as a result of COVID. And again, in the patient group yesterday, there was a couple of patients who made very distinct choices about the kinds of therapies that they were going to do because it kept them out of the hospital. There was a number of different benefits. I guess the question I wanted to ask was, Scott, I believe you raised some of the options here too, but how frequently were different or alternative treatments used during COVID? Who was making that decision? What did we learn out of that?
So I think that early on in the pandemic, there was an effort thinking that we may have had to actually scale back care substantially, about setting priority frameworks for things that originally things that had very perhaps low value in the short term, like follow-up, some medications, and then obviously at the highest priority, life-saving urgent therapy, and thinking that really as we head into the pandemic, not knowing what we were going to expect, that we had a priority system that we could scale back in an orderly fashion. Fortunately, I think that I think Ron has pointed out the surgeons really had to scale back, and Brandon's told us how that's impacted on him. Fortunately, we were able to actually, when we look at our volumes, our actual volumes were maintained. It became more difficult. Families weren't able to attend. A lot of it was done virtually, but we were able to maintain our volumes and never really had to scale back. But the other part of that was using alternate modes of therapy. Charlene mentioned switching to oral therapies when possible, shorter course radiation.
And I think yesterday.
Yeah, and I think what we tried to do, obviously having the decision with the patient, but wherever possible, and I think probably also relates to Ron's comments about the use of TNT, is we tried to ensure that those were part of multidisciplinary case discussions, so that these weren't individual one-off decisions, but these were, given the constraints that we were looking at, both on the oncology and on the surgical side, what's the best we can do, and looking as we have. And so I think that's where our multidisciplinary case conferences and our system, which is really based on multidisciplinary collaboration, really stood us well. Those continued on Zoom, and they've always been a forum for discussing very difficult cases. And here, that's where those discussions took place. Is it reasonable to give TNT? And perhaps many of us hadn't given TNT before. Is it reasonable to use short course for this patient, or at least to discuss it with this patient as an option? Is it reasonable to use this neoadjuvant approach rather than, if there are delays in surgery? So I think those decisions were made as part of an overall plan about having to scale back therapies and use different models of therapy. And we tried to make them in a multidisciplinary, consensus fashion wherever possible.
I'm wondering.
One other thing. Oh, sorry, Charlene, go ahead.
Oh, no, nothing. I was just I wanted to just make sure I clarified. Anne-Marie, when you said alternative treatments, do you mean a change in their treatment, or were you talking about sort of non-conventional therapies as well?
I said that very broadly. And choice of changes to, it really was fairly all-encompassing. Thank you for clarifying that.
Yeah, I because I think, as Scott's talking about this, like all these memories flood back of these very long conversations, difficult conversations with patients about sort of who are currently on a certain path of treatment, and there was a plan that was in place. And then the pandemic happened, and we had to kind of, be nimble and adjust the plan. And then to have these conversations usually over the phone was even more challenging. We're trying to make big decisions about maybe it's time to take a break, a holiday from chemotherapy. Maybe this is the right time, or shift, de-escalate chemotherapy, because it's not just visits. Patients were worried, what if I'm on this high intensity chemo and I get COVID and things like that. So you know, I don't know about anyone else. We were all kind of like flying by the seat of our pants initially, just trying to say, how do we manage that uncertainty and still make sure our patients realize that we're still here. So, you know, I will say that when, you know, in terms of non-conventional therapies, you know, I had a number of patients who, you know, were hesitant to come into the cancer center or didn't want to come in for chemo and only be by themselves. You know, like Scott had mentioned, we had to restrict capacity, who took a break, and then during that break, and then maybe this is a BC thing, you know, really chose to kind of work on with alternative therapy, you know, practitioners, integrated care, however we want to, you know, call it, and would, you know, be on various regimens trying in the hopes that that would keep their disease in check while they're off chemotherapy. And so, you know, it's a tough situation to counsel patients through, because on the one hand, we're kind of saying, you know, we are going to change your standard treatment. But on the other hand, we know that there is really no certainty of benefit from that approach. And I had a few patients who kind of opted that route as well, who were like, I'm going to just take matters into my own hands. And so, I mean, I think, I'm not sure there was a right answer. I think about how I would do it differently if I had to do it over. And I actually think, you know, a lot of those decisions were patient driven. Like I really felt like a shared decision-making model worked best. So, you know, at the end of the day, it was for them to decide what they were most comfortable with.
I love that last statement, Charlene, and I want to hold thoughts on that and bring that back to the table. But so I wanted to bridge now into a unless there was another comment someone had wanted to make urgently, but I wanted to bridge into the concept of backlogs, and knowing that we've got pressure points everywhere, particularly from a resource perspective. We have burnout facing the system. We can't work more than 150%. What are some initial thoughts on today, things that we can do to take us out of this pressure cooker of backlogs to clear down the system? Some of these solutions are very long-term, but is there things that we can do today, short-term, to make things better?
Oh, man.
Yeah, that's a tough one. Let me start by just stating up front that medical oncology is the only unit and division that never shut down. When Department of Medicine, everyone else closed, we didn't close our clinics at all. So, you know, I think the issue of dealing with the backlog, of course, comes from the surgeons, will spill over to us. Clearly, it will spill over to us. Resources, more people, nursing, and medical oncologists. I think that's where the solution is going to start from. We, as people who are already working full out, can't keep doing what we're doing. I think, you know, burnout is, you know, I luckily at my age, I don't burn out because the burnout is in the younger people. It's not the older people. And there's lots of data now to show that. It's the younger people. It's not the older people. Maybe because we've learned how to be resilient. Maybe we're just used to taking it without lying down, and we just do it. So it's the young people that I'm worried about.
That's really interesting statistic.
I just met Dr. Burks' definition of young. I meet that definition. I felt burned out, I will tell you.
That's a really interesting statistic that I did not know.
Yes, it's young. I was shocked when I always thought it would be, you know, the older generation, but it's not. It's the younger generation, and they're the one. They actually raised it to me when I interviewed all the junior staff that was hired over the past year for the last number, I guess, before their CFAR, which is their initial, you know, getting fully appointed to the university. So it was about 20 of them, and that they're concerned.
Yeah. So even beyond surgery, access to screening. as an example. That has to be backlogged equally.
Yeah, if I could just make one comment. The
Yeah.
first step is everyone getting vaccinated and us moving past the pandemic. I think that the fact that this far into the pandemic, we still have ICUs full of patients, with COVID, is distressing to me at multiple levels. But obviously, of course, the fact that you think it's this is preventable in many cases. Obviously, not everyone, but I think we have to still put the sort of keep the foot on the gas pedal in terms of that messaging. I still have patients who haven't been vaccinated, like long, exhausting conversations about, but there's a mindset, unfortunately, that has set in for a proportion of people where even in the face of having cancer, active cancer, being immunosuppressed, that, they've made that choice. So anyway, I'll stop there. That's my little rant.
I agree 100%. I just had a gentleman 3 weeks ago today, comes in, last cycle of adjuvant chemo in his early 40s. Never believed in vaccination. He's a bit tired, he said. And I said, well, it's your 6 months of chemo. Goes over to get his chemo. Nurse takes his temperature. He's got a fever and he's positive. And he ran around, this was a Tuesday. He ran around Montreal all weekend, the weekend before, that 2 days earlier. I saw him, our chemo nurse saw him. He was in the chemo suite. Now, yes, we all masked and we had visors on, but you go home and you're waiting now for 14 days for the shoe to drop. So Charlene's 100% correct.
Get vaccinated for sure. Other thoughts on relieving some of the backlogs, whether it's related to screening, diagnosis, surgeries?
I don't have a quick answer solution for this question really, but I think related to the backlog, I want to circle back to the mental health and well-being of a lot of physicians and nurses. At least in Calgary, we're quite concerned about that, especially because we're knee deep in the fourth wave. Alberta has been very, very hard hit. So a lot of physicians are actually being very creative and innovative in terms of doing lots of wellness activities for the physicians and residents and fellows. And it doesn't address the backlog problem per se, but perhaps it allows us to have better coping within the context of the backlog, because we are very concerned about burnout. And so again, I think that's been a main priority in terms of how we're managing and coping through the fourth wave here in Calgary and Alberta.
And knowing that you will have to work 150% just to relieve, but can you give us some examples, Winston, of some of these wellness programs that others might benefit from?
So one of the things that we've done within the medical oncology and radiation oncology department are sort of wellness Zoom lunches where we sort of meet sort of like in this forum or platform.
Yeah.
And it's actually been very well attended to our surprise. It's common for 20 or more people to show up, really to share stories and to share ideas of how we can kind of manage the stress. And I think it's been actually very therapeutic. The feedback has been very, very positive. Again, because of various policies in the hospital, they're not done in person. But having said that, I think many of us are reaping the benefits of having that forum to either vent, gripe, just share stories or ideas. And so I think to our surprise, it's been a lot better received and attended than we had initially expected. So that's one thing that we've been doing quite regularly to good success, I think.
Who leads those, Winston?
It's sort of a sharing session, so no one actually leads the session per se, but certainly it was endorsed by various faculty members in the department, and once again, I think something simple like that has it's cost neutral. It doesn't cost a lot of money, but having that platform to just talk through things and talk through whether it's personal or sort of professional issues, I think has been very, very healthy. And it's been ongoing for some time now. It started maybe last summer, and it's still been going on a continual basis. So it sort of speaks to, I think, people's reception to it. Yeah.
Okay.
I think still with some of the backlogs, like especially surgical backlogs, where you're seeing ORs now open on the weekend, there's no amount of working hard that can make a surgeon go
Right.
twice as fast and do a hemicolectomy in half the time that it normally takes. And then the other affected departments, things like anesthesia, perioperative medicine, the laboratory, there's going to be a lot of resources that need to come into these departments so that we can help pay the staff for overtime, so that we can help pay the staff for the extra volume and the extra hours that they're needing to work just to address this. And while the burnout may come and it may hit some of us, maybe the younger ones and not the old ones, but we still need resources to get to start to make a dent into these things, and they really haven't come yet to a lot of parts of the hospital. So we are struggling with that.
Yeah. So maybe we can probe into this a little bit, because there's another side of this that says we need to keep people out of surgery. We need to diagnose them faster. We need to push the whole screening aspects, particularly for colorectal cancer, faster, so that people don't end up, certainly the delays in the system related to the pandemic. There's lots of literature about, people showing up in later stages of cancer, et cetera, et cetera. What kind of conversation is happening around prevention and earlier screening and moving that process up to keep them out of surgical units?
I think it's hard for us to comment. It's hard for me to comment on that. Because it's a different world that happens in primary care offices and gastroenterologist offices and things like that. And I think hope that they're doing their job, but we don't get as involved in that as you might think. So the second part is, though, in terms of managing the backlogs, I think maybe part of it's denial, but we haven't seen the increased volumes. We're still bracing for them. I think the watchword is different models of care, because we're not going to be able to train new people immediately, right? And we're not going to be able to get that immediate influx. So we're going to have to do things differently. I think we have learned. I think that virtual care has relieved some of the space and time issues, and I think that's more convenient for patients, perhaps allows you to see more patients. So I think that some of the innovations that have come to manage the problems have given us some effort. As we ran out of ICU beds or ICU staff, actually it wasn't the beds, it was the staff. They had to start using different nursing models and team nursing, et cetera, in situations where there used to be 1-to-1 nursing. Now there had to be 4-to-1 nursing. Mm-hmm. And so, I think that some of the kind of crisis issues that we had and things that we learned from different models of care during the pandemic may serve us well. But I unfortunately, it's difficult to come out with, it's going to be a tough thing. And as we're dealing with shortages, we now have vaccine mandates in our hospital, and this is happening in many hospitals across Canada now, and that's causing more staff shortages. We think we have to do it to maintain the safety of our staff and keep our hospitals operating, but that's exacerbating it. So we haven't seen, I haven't seen in our center yet that wave of the increased activity coming through yet. But I think we're going to have to keep it, so Winston's, thanks, Winston. I think that's, keeping the folks who are here healthy and as happy, as well functioning. I thought at first you said these were oversharing sessions, and I thought those might be interesting as people share too much information or something like that.
Well, sometimes they are oversharing, sometimes on occasion.
But, we have to keep the people here healthy, vaccinated and I think I can't name off a long list, but we're going to have to think differently and creatively. I think we have, right? I mean, I think one of the things I think that we've learned over the past 18 months is, prior to the pandemic, we're thinking, we have space issues in our cancer center. I think it's a common problem. And how are we going to virtual care, that's a great idea. Let's start doing more of that. No way it was going to move. And all of a sudden, very quickly, when the time came, we shifted to 70% virtual care. So I think that what it showed is that when needed, we can innovate and change our models of care very rapidly. And hopefully we still have the energy to do that. But I think that, I think that's what we're going to have to stand back on, is our ability to, whatever things confront us, do we have a creative way? And a lot of, I'll have to say that one of the great things, in our hospital is that there is, despite everybody being tired, it really has been a great team effort, right? I think that everybody's pulled together in Ontario. All of the hospitals across the province really pulled together. So I think that there has been good support, and I think Winston's comments attest to that as well, is that there has been a very supportive atmosphere within our hospital. I think that's probably similar around the country.
Yeah.
So I have to jump on something Scott said. That's about virtual care, because I can't let it go. I am not a lover of virtual care. I think it has actually created more work for the oncologists, and I'll tell you why. When patients come to the clinic, it's a one-stop shop. They get seen, they get their blood, they get their scans organized. That's it. When it's virtual, we have to organize. We see them, we talk to them. We then have to get the blood work done, usually elsewhere. It gets faxed back to us in the CBC, and then the chemistry, and then another day the CA comes in, and then another day all of it comes as one report. We then have to book the CT separately, and that's often done by our offices instead of the clinic. So in some situations, virtual care works well, and most of us in our division at least have all pretty much uniformly said it's created more work for the medical oncologist than it actually has relieved the work. So yes, it's less visits to the cancer center, but the workload is still there on us, our administrative assistants. And so I don't think it's relieved the workload. It's just offloaded it somewhere else. So, and most of our patients, I have patients now starting to come back to see me because they want us to be seen. They want to be seen. They've gone a year without seeing us in many cases. So not everyone's a lover of it. I am not a lover of it. And I think there's a workload issue that has increased because of it.
I love other people's opinions, because in some ways, virtual care is being seen as the solution in certain circles, and it's changed the world, and et cetera, et cetera.
Yeah.
I like the alternative pursuit.
One patient group that's been really adversely affected by virtual care in the cancer world is melanoma. And you can see a lot of the advanced presentations of melanoma across the country right now. And so that, whereas sites like colon cancer might be a little bit more amenable to these virtual visits, patients with concerning skin lesions who are seen by their primary care physician over a virtual visit, they'll really be suffering for that in the long term. And I think that we might have made a big mistake incentivizing virtual visits at the start of this pandemic.
Yeah. I think Brandon's comment's a really good one, because it's not a one solution for everyone. Obviously, it has to be in the context of the right clinical setting. So, I think virtual care has generally been a positive in my practice. I agree with Ron about that, there were inefficiencies. So we had to change our workflows to adapt to the seeing patients virtually, which wasn't great, but I think it has managed. We've kind of figured it out and adapted accordingly. Right now, still 50-50. 50% of my practice is in person, 50% is virtual. When patients are booked back, they're given a choice sometimes, and I don't take it personally, but a lot of them just want it virtual. They don't want to, parking, and it's a whole day and coming, and they would prefer to be at home, and you do either a Zoom call or a phone call. And so, I think it's here to stay even post pandemic. And I do agree with, the fact that it has addressed some of our space constraints. So, I look at that as a silver lining of the pandemic. I think it's a, I think that has been a positive step forward for the appropriately selected patient.
Appropriately done.
Yeah. I was gonna add that we've been increasingly more selective in terms of who we would offer virtual care to, because not all patients, I think, are suitable for virtual care. I think we've all had, the occasional case where things get, things slip through the cracks a little bit in terms of not seeing a patient for months on end. And as a general sort of, soft policy, we, as a department, we do tend to encourage like an in-person visit every second or third visit, just to make sure that things are still, going according to plan and on track, because sometimes people don't always report what they should be reporting to us over the phone or over Zoom. So I think there are some maybe safeguards now that that we've implemented, so to speak, to reduce the number of potential errors or mishaps that can happen.
Yeah, that's a great bridge to a question I had, because is there any quality of care issues related to virtual that you've experienced, seen, or concerned about?
I think it's a nuanced topic, as we've heard, and I think that as an example of being able to do a rapid change faster than we thought we could, I think it's a great example. I think as a learning experience of selecting the right patient with the right disease, the right stage, et cetera, who's good, who's appropriate for a virtual care visit, it has been a good learning experience, and we're still learning. I think, as Charlene pointed out, patients have liked it. I think that, as Ron has pointed out, what this does, it is another pressure point, and it has exacerbated a problem in the healthcare system that has been expanding, I would say, a lot over the last decade, in that this bureaucratic burden. When I used to fill out paper forms, compared to having multiple computer systems, and that is exacerbated by virtual care. Hopefully there can be some innovative ways to adapt for that. So I think it's good for patients. I think it's shown our ability to adapt quickly. Yeah. I think that as we learn to select, as we learn to select the right patients and have the right guidelines, like Winston has said about, reasonable interim visits, maybe disease sites, I agree, like skin, where it may be less appropriate. I think there probably has been some quality of care issues, but I think that we're learning how to adapt and minimize and mitigate those.
Yeah, I agree that it's nuanced. Thank you, Scott. I'm going to move on to, there's been a lot about, I know you're all bursting at the seams to share some new ideas. I just want to do a quick one each. What's your number one learning from the pandemic related to your practice? Charlene, go.
Oh, man. I value the camaraderie among my peer group more than I ever have. I think that at the end of the day, I feel like you can't serve others unless you look after yourself, either as an individual or as a community. So I think that has probably been my biggest takeaway in terms of moving forward and building resilience for continued challenges.
Collaboration and teamwork. Fantastic. Ron.
Yeah, I would have said a very similar thing, especially, as Scott, I guess, mentioned about tumor boards and multidisciplinary tumor rounds. I mean, it's all done virtually now. It's great. I mean, for example, I had tumor board tonight. If I get home in time to do tumor board between 5 and 6, I'm home already, not having to come home at 6:30 or 7 o'clock or 7:30 sometimes. On the other hand, I miss being with my colleagues. I miss those consults that we do after tumor board that aren't on tumor board, that you can speak to the radiation oncologist and the surgeon, and we don't have any of that. And so I think, again, the camaraderie, I think, is a huge one. I think that's probably I don't know if it's a learn, what I guess maybe is that learn to appreciate things that we often just take, we always took it for granted. As I said earlier, having our ad boards and getting together, going to the conferences, I know people complained about ASCO, but I got to tell you, I don't care if there's 42,000 people there. To sit in a room by myself and the session is over and I ask, so what did you think? You think we should change practice? Well, I'm talking to myself. You know, my wife's a pastry chef. She's not a medical oncologist. So I can ask her and she'll say, well, put more flour in. I don't know. But, you know, so I think those are things that we, you know, we've always just taken for granted. It's always going to be there. And it's been ripped away from us for almost 2 years now.
Brandon, your number one learning?
Yeah, no, I'm sorry, but I'm really unoriginal here. And I think that what Charlene and Ron said really resonated with me. And I miss spending time with my colleagues, especially as a pathologist, where we're isolated to begin with. And those, the hour we spend in tumor board, that might be our social interaction for the week. And you know what Ron said earlier about the trainees missing out on things like ASCO, I think that really resonated with me as well. And it made me reflect on what an important part of my training that was. And having not been out to a conference and not heard any new live presentations in the past 2 years has made me really miss that.
Thank you. Winston, you're number one.
I think very much the same. I think, speaking for myself, I think I've gotten a lot better in terms of asking for help. You know, we've all had colleagues who had the sniffles or whatever and needs COVID testing and cannot come to work because they're not allowed to. So to ask for a backup when we need it, I think has been somewhat novel actually, whereas before COVID, we would still go to work and kind of run our clinic. So that's been nice to see and experience. And I think that's also here to stay, which is a positive thing. So very similar to what others have said already.
Great. And Scott, last word to you on this one?
Yeah, I think I share a lot of the other sentiments, but I think, you know, maybe expanding on appreciating what we have is, you know, despite all the things we've said about the challenges in our healthcare system, we work in a pretty good healthcare system, right? And I think that the last year and a half has given us a little taste of what working in a really constrained, really stressed, situation. And this has been, you know, like life in general, how fortunate we've been up to this point, you know, where some of our colleagues in other places in the world have to deal with this on an ongoing basis of shortages of people and space. And so I think, you know, definitely, you know, miss, you know, the broader gatherings of people. But I think made me recognize how good we have it, even with our challenged healthcare system, how lucky we are.
Yeah, it's the what I'm hearing is that we need just this concept of multidisciplinary collaboration is just embraced and an important part of what we do. So I want to bridge now into some of the ideas. I mean, our goal here really is to understand how we can build a more resilient healthcare system. And so maybe I'll start the conversation from a place that says, if you knew then what you know now, what are those things that you would like to implement into your day-to-day practice? And if that is a challenging question, it's really just what I'm looking for here is what improvement, what changes do you want to see based on what you've learned in the past 18 months or so, particularly given the situation we're in with cancer today. It's a very open-ended question. And I know that you're all surgeons, but lots of conversation today on prevention and wellness and good health versus just fixing somebody who has had that needs surgery. So I'll open the floor on that.
Well, let me start by saying I think we could have learned our lesson from SARS. And I think that's one thing we did not learn. Is that our fault? Is it the government's fault? You know, we knew SARS, we were lucky with SARS. You know, it was mainly a hospital-driven virus, and so it didn't get out into the community. And so maybe the impact wasn't on governments as it was so much just on the healthcare workers working in the hospital. But, you know, there were opportunities from SARS that were not taken advantage of and could have prepared us a lot better for for COVID. David Naylor, most of you probably know David Naylor or heard of David Naylor, and he'd been appointed by the government. Nobody listened to a thing he said. David is absolutely brilliant, and so I think that's probably the first thing, is that we didn't learn, all those years ago. Was it 2003? I think it was. Scott, were you a resident then? Did you have to live through SARS or at very early on in your career, right?
I was on staff for about 5 years then, but it was intense in Toronto, and we thought it was and it was certainly our hospital had several people get sick, and Toronto was hit hard, but it was a walk in the park comparatively compared to what we had now.
Yeah. And so
Can I put you on the spot, Ron? Is you talked about some of the opportunities, some of the good learnings that came out of SARS. What needs to be reenacted so we don't create the wheel, particularly in the context of a new kind of system?
Well, I think let's start with the fact that we, at the beginning of all this, there was a shortage of PPE. We should never have been in a position where we didn't have PPE. I think a lot of people got a lot of things wrong at the beginning. I remember the very first day of this, when this all started, just something very simple. The revolving door in the back entrance to Sinai was still revolving. There could have been 5 people going through that revolving door when they're telling you to space apart, 6 feet. And here we are cramped into a revolving door. I said, why is this door revolving? Then a few weeks later, they say, okay, you have to, you have to start wearing a mask, but your patients don't have to wear a mask. And I said, well, that makes no sense whatsoever. And I'm not seeing one patient unless they have a mask on too. I don't care what the hospital says. I mean, they got it wrong multiple times. So I think, they should have been prepared, even just with PPE. We shouldn't have had to scramble to find masks and shields and all this stuff. So I think that's just a very simple thing. Maybe it's not so simple, it's money. But it's, that this is something that can't happen again. We need to be ready to go. And I guess the simplest thing for me is, let the government give us the money, and let the people who know what they're doing, and let the governments stay aside. This is not political. And this should not be a political thing. This is a healthcare issue. This is a public health issue. It's not politics. They should all be working together. And so I think that's something completely different from what we're involved in. But I hear Andrea Horvath in Ontario totally always complaining about Ford, but she never has a solution. She never gives a solution, and they don't work together. I think governments now need there's no such thing as different parties. It should be all one group working together. So I'll get off my soap opera when it comes to that. I could go on and on.
Thank you. Well, today's a new day. We have a new government.
No, we don't. It's the same government, same story. We're just $600 million poor. Don't get me going.
I agree 100% that it starts with public health, right? And even though it's not a political issue, it's politically expedient for any government, even after SARS, to not maintain that investment in public health. And you're right. We saw it early on in inability, just to do contact tracing. We're seeing it now. I think there should be a heck of a lot more rapid testing, right? Happening, and it's not policies in schools. And I think that if I think there has to be investment in public health. And I think that the ability, I think governments kind of thought that it was easy to cut public health funding, ventilator reserves and PPE reserves, because nobody would ever know about it or suffer from it. Well, hopefully we'll learn, but you hope, the second thing is that we work in a healthcare system that was pushed to the limit, that we had people in hallways, at least in Ontario we did. We had, a flu surge, even with, a flu surge every year that pushed us to the limit. And we have to be able to make the investment to say that we can't work at that 105% capacity. And a lot of it has been, availability of long-term care placement and filling up of acute care spaces with people who are better in long-term care homes. Unfortunately, the people in long-term care homes suffer disproportionately in this pandemic, but I think we need I think we need to invest in safe, excellent long-term care homes, get our acute care hospitals so there's some capacity to deal with even a flu surge, and have a very strong public health system, because I don't think the next one's that far. Next pandemic may not be that far in the future.
Yeah. So building on that, knowing that there's a strong possibility, especially related to the cancer care ecosystem, what are those things that you would want to change now that you would want to see in place?
Well, I think, I just wanted just to comment on what was just discussed and then to answer your question, Anne Marie. But
yeah,
one of the things that, I wish I knew then that I know now was kind of how long this was going to play out in terms of, I think in the early days, it was kind of this sense of, maybe there's just this one wave, that a lot of the mitigation strategies were a bit drastic, right? But I think because at the time, it seemed like the only healthcare issue that existed was COVID, and everything else, including cancer, suddenly took a back seat. And I think we now know that given the sort of the longevity of this pandemic, that was not, the smartest thing, because it both from healthcare workers, like all kind of overconsumed by COVID, and the public as well, we're not recognizing other medical issues that have always been with us and continue to be with us through COVID. So not being so tunnel focused on COVID and at the peril of other real illnesses that, continue to require attention. And then, to your question about sort of, the second comment was about, remind me.
Yeah, no, that was fine. What it's essentially, if you had to recreate the cancer care system, knowing what you know now, like what are those things today you would want to see put in place? And I would like to see. Go ahead.
And I think I was sorry. I forgot that train of thought. But the capacity issue is, the truth is that even independent of the pandemic, we know that the incidence and prevalence of cancer is on an exponential rise. We live in an aging population. We live in a time where thankfully patients are able to live longer with cancer, but they're living with cancer that's requiring treatment and resources over a longer period of time. So this increased incidence and prevalence and complexity of care. We've always known this. This isn't like something that COVID made us realize, but I think the fact that we have to build capacity, both because of COVID and because of the reality of what's happening with cancer, is maybe now starkly in front of us more than ever before. And you can pour money into buildings, but it's the human resource capacity, I think, that's the big one. And how do we ensure that we have, nurses and pharmacists and oncologists and surgeons who will be available, to address that capacity. Part of it has to do with models of care. We can be more efficient in how we deliver care. Part of it has to do with really leaning in on whatever is preventable, trying to make sure that, if there's scenarios in which we can prevent cancer, detect cancer early so it doesn't require all those treatments, we need to bring that to the forefront.
Yeah. May I build on something important that I think you said, Charlene, and maybe I'll ask the question broadly, is the role of data. And again, it's another very large conversation, but access to data, types of data. How is that used to help you in the past year? What are those things that you want to take forward into your practice that you went, that was fantastic, I need more of this?
I was going to chime in beforehand anyway, in terms of the data piece. I think overall, when I chat with colleagues in other countries, I feel like the Canadian response to the pandemic has been very fragmented and disjointed. Each province has its own policy. Each province has its own vaccine passport. And I think data is very much the same. Now we're seeing a trickling of data coming out from different provinces and centers about how COVID has impacted their care and care trajectory. And I think there is something to be said about, federal data or national data, so that we can all learn from each other. I mean, it's hard to sort of implement a national data infrastructure, but I think if that could be achieved, that would be ideal. And I think to that point, I also think that the data lag that happens in Canada is very long. We're only now starting to see some data coming out, and it's been 18 months already. So I think there's value to have data, earlier and faster. But again, I think how to implement, operationalize that is the big question.
Yeah, I know it's a bit of a big, hairy, ugly question, isn't it? But is there something that we saw during the pandemic that allows us to accelerate that? What are some of the solutions that you may have seen in your day-to-day that would allow a healthcare system to say, I need data earlier, faster, I need this has to happen?
So one thing, it might not be answering your question directly, but taking a positive out of the pandemic is that we saw drugs become approved faster than we've ever seen before.
Yes.
And paired with that, we saw diagnostic tests, like complex genetic tests, become very cheap and very widely available very quickly.
Yeah.
And access to new drugs and moving them through the regulatory process and access to testing are two huge issues that continually plague cancer patients in Canada.
Mm-hmm.
So if we could learn from this global effort that forced these new drugs and tests into like this lightning speed approval and deployment, and apply some of those principles within cancer care, knowing that we don't have the same global pressure for a disease that's not affecting everybody, but only affecting a few of us.
Mm-hmm.
I think that'd be a really positive takeaway. And I don't know how to do it, but I think if we could figure out a way to get that done, we'd all be better off moving forward.
Mm-hmm. Mm-hmm.
Yeah, I think Brendan makes some super points. And I think, and then Winston touched upon it, I think this fragmentation into provinces, I think, is something that maybe should be done away with when it comes to a pandemic like this. It should be a national strategy, not a provincial strategy. And we've seen every province have a major wave. I mean, Ontario was in big trouble in the spring. Alberta's in big trouble now. And I think that our federal leaders really need to take hold of situations in this kind of, here. And when you listen to other countries, you don't hear of a passport in, some small province in France. It's a French passport, right? It's an Italian passport. It's the US is a different story. We won't even go to the US because they're I think a disaster altogether. So we won't even go there. But I think this should be a federal issue. I think that information systems need to be created. You just have to look at, we don't have to reinvent the wheel. It's out there, right? I mean,
Mm-hmm.
Ford is reinventing the passport when Quebec already has one. Why are we doing that? I mean, Israel is probably the best example of, in the world in terms of how data has gotten out there because they have 4 major healthcare systems. Well, in Ontario, we have one, we have OHIP.
Mm-hmm.
There's no reason why that couldn't have been utilized to get data,
Right.
contract data,
What kind of data would each of you like to have had? If I could just paint a broad picture and say, look, in the next 6 months, we could wave a magic wand and types of data related to cancer care is made available to you. What's missing today?
I think an adequate, I mean, we've been talking about these backlogs, and what numbers of patients are actually out there, who haven't been diagnosed, who are waiting for. I think that's I think that BC, Alberta, Ontario actually have, because they have quality-based systems, and I'm not gonna, Winston is the expert here. But we actually have pretty good data systems for tracking people once they're in the system, time to colonoscopy and things like that. I think we have good ways of projecting, based on previous volumes. I think the interconnectedness of that data is missing, as we've discussed. I think, in fact, the data for cancer systems is much better than for other parts of the healthcare system. Because of the provincial, because the provincial cancer system. And, Winston has been a you know, a big promoter of unifying that. But I think that, you know, where are, you know, given, you know, 2 years ago, 2018-19, where were the patients coming from? Where are we seeing those now? Are they in the, you know, where should primary care providers be increasing their screening efforts? You know, where are, you know, the surgical volumes down and things like that, so that we could, you know, plan. I think we're waiting, and I think we've had some projections, but I think that's the most important piece.
Yeah, well said.
You know, I think I'm very disappointed in what's come out of here, though, in general, because as Charlene mentioned, Mustafa presented the Quebec data. We don't have that. If we do, nobody's telling us what it is. Nobody's collected it. But, you know, in Quebec, they could tell you exactly how, you know, how far down we've gone with FBOT and colonoscopy. And, you know, we just listened at ESMO. The UK has huge thousands of patient databases, and they can tell you exactly what percentage of patients never got to surgery when there was a total lockdown versus a partial lockdown. Are we collecting that data? Do we have that data? Cancer Care Ontario, at least in Ontario, thinks they have everything related to oncology in place, but I don't feel that we have those information systems, or nobody is really, you know, looking after those databases and getting that kind of information out, because we're only going to learn what to do by knowing what has actually happened. So we all think we know what's happened, but let's get some hard and fast data in this country.
Okay. Other thoughts on data? Vincent, I can give you the last word because you are the expert here.
I mean, I think others have already, you know, mentioned the major themes. I would say, as a blanket statement, I think, you know, data sciences in general is pretty under-resourced in Canada. There's not much funding going into it. So, I mean, all of the work that Ron and Scott and Charlene described and Brendan described, you know, requires manpower, right? So hopefully one of the lessons here is to devote more resources to data sciences, because I think we learned from, you know, the past, and there's strength in data, but again, it takes time and effort. So hopefully there'll be, you know, future investments in this area so that good work can be done.
Great, thank you. Scott, I wanted to go to a couple of comments you made. It was referenced, in fact, a few of you did a few times, new models of care, and it was rather a big statements. It would be interesting, I think, to get a deeper understanding of what those new models of care might look like in a more resilient healthcare system. What are some of the things that you think you could share based on these new models of cares that were made on the fly as you were sitting in your office talking to patients or talking to colleagues?
I think that virtual care is the biggest one. I think that some of them are relate to nursing workforce, quite honestly, because that's where we've seen the biggest stresses, in terms of having more nurses who are trained in you know, basic oncology services, so that you know, we have a half medical, half oncology ward, and we're making sure that all of the nurses on that ward now have some basic oncology knowledge, so that they're able to, you know, if there's shortfalls in either one, they're able to cross cover. I think that model, you know, I think it's looking at the use alternative, not in the complementary sense, but in alternative treatment models that might be, you know, first of all, the patients might prefer, but also might be use less resources. So those
couple
are
examples of that.
of course,
Scott?
radiotherapy would be the biggest one that I talked about. Oral therapies are the two that come immediately to mind.
Yeah. Other thoughts?
I was going to add that, at least in my practice and those of my colleagues, virtual care still usually means a phone call as opposed to a video conference. And so in that vein, I still think that, you know, virtual care, that whole area needs maybe a bit more streamlining, because I do think, to Ron's point, I don't think a virtual appointment would replace an in-person appointment, but certainly I think being able to visualize them on a screen is probably better than a phone call. But I think at least in our center, the vast majority of virtual appointments are still phone call based because of resource and planning issues. So if virtual care is here to stay, which I think it is, I think some work needs to be done to maybe further, strengthen or improve the way we deliver it. So I'm not sure what my colleagues think on the call.
Yeah, Charlene, I think I will say that we did establish a Zoom virtual health platform to be able to allow that video conferencing. But the challenge was that there weren't resources in place to train patients on how to use Zoom and inform them. So it's kind of left to me, like to walk them through it. And then patients have different kind of technology challenges. And then the other practical reality, and I'm ashamed to say it, my patients know this is true, is that my clinics always run late. Like I'm usually, we all are, we're always often double, triple booked because that's how we're going to get patients in. And so if a patient's waiting in the waiting room, that's different. But when they're on the Zoom, like virtual waiting room, it's very hard to manage. So I probably do more telephone calls, but I'm sure there's a way around that mimics better the reality of how we practice in person. But it's kind of it's a learning curve.
I'm going to ask, just as a build question, is there other technologies that oncologists are embracing as part of their practice these days?
I think there are technologies we could be embraced. I can only speak for PC, but one of the things that we've also kind of recognized is the importance of patient-reported outcomes. So if patients were able to, before a visit, whether in person or virtual, log in real time, what their concerns are, or what symptoms or side effects they're experiencing, and then that would really better inform the discussion with them for, like, in our world, which is talking about chemotherapy and how they're doing. And so, but we don't, and that would really, if we could cull that data in a way that I could get a snapshot, it would actually improve my efficiency in clinic and also hopefully lead to a better experience for the patient, because they're often struggling to remember things, and 14 days later everything seemed like it was okay because it's so I think enabling patient reported outcomes. And I think a lot of
how would we do that?
So I was going to say a lot of these technologies require a shift in how we think about who's delivering the care. So to Scott's point about models of care, one of the things that we talk about a lot is everyone operating at the top of their license, meaning people really being able to use the full skill set they have to be part of the care team. And in resource-strained environments, especially where we don't have enough nurses, or there isn't capacity built in for other allied healthcare teams, it kind of by default falls on the oncologist.
That's right.
And we're not good at it because it's not possible to do all those things, to also teach your patients how to use Zoom and counsel them on their medications and, look at, and also make their treatment decisions. You're not doing justice to your patients that way. So a true kind of model that builds on really a team-based approach, not just your oncologist, is how we have to think about it.
Yeah, I think that whole realm of digital health, virtual care is part of it. Digital patient-reported outcomes is part of it. Using just getting patients in and out of clinic efficiently, right? So those wait times, so that, there are, and I am not an expert in this. Fortunately, I have somebody in my department who is, and I think I think it's just lack of time, quite honestly. But I think there is thinking to the future, lots of room for innovation in what Charlene has described. I think when a patient comes in and registers, based on AI algorithms, you can have it so that when they come into your clinic, and you open their electronic patient record, the key elements of whatever you need to see, whether it's lab work or patient-reported outcomes. So there's this kind of brave new world, and I think that digital health spans a lot of space. But I think that investment in, as we train the next generation of oncologists, looking at people who have that ability to look at artificial intelligence, use of not only use of data, but use of real-time data. As Winston said, we are the lag in data is a big thing if you're basing decisions on registry-based data. But we're I think I saw on Twitter, Charlene, that you've recently had the introduction of a new electronic health system. We are getting a similar electronic health system for our entire region. And so think about, if that was for the entire region or the province, all of the information there, and I'm not going to be able to do this, but smart young people like Winston and folks who know about AI are going to be
You can do it, Scott. I know you can do it.
No, I know. No. I think that, but being able to harness that real-time data. So as I'm sitting down in front of the patient and don't have an electronic system that's a barrier to care, but is able to bring up the information I need, bring up the trials that I need, to know to treat them effectively, bring up the clinical trial options that are available for them. I think that, the technology is there. So I think that, it's a little bit of blue sky thinking, but I think that, Charlene opened this up, the realms of possibility for digital health in particular in cancer, I think are something that we're going to have to, as we emerge from the pandemic, hopefully be able to start benefiting from.
Yeah. Winston, I'll give you the last word on data. Is there any, shall I call them pilots, pods, any evidence of an electronic healthcare system that is top of the game, that is a usable benchmark for a system going forward?
The short answer is they're not ready for prime time. I mean, there are a number of initiatives happening in Canada. There's initiatives to federate data across different provinces. Right. But I think the time horizon for those initiatives to materialize is probably at least 5 to 10 years.
Is that right?
There's also lots of talk to what Scott mentioned, learning health systems where data are really produced in real time, and how one patient does affects how you might treat the next person. But again, that's sort of in conversation. But how long it takes to sort of operationalize is TBD and to be determined. So there's talk around it, but again, it also takes money and resources. So oftentimes that's the rate limiting step.
Good. We've only got about 10 minutes left. Shocking how quickly time can advance with such great conversation. So I wanted to focus the last bit of time we have on, let me call them new services that potentially are not in the system today, maybe there, but just not elevated enough. And I don't mean just patients, services. I want to break this down. Services for patients. I'll give an example. Should we have survivorship clinics? Should we enhance our palliative care in some way? That's one part of the conversation. But I also want to go back to a point that's, what are services for your community that need to be enhanced in a more resilient system? Services that allow your community of oncologists to be the best they can be, especially today in a very difficult time. So let's start with the services for patients that are potentially outside of the specific surgical or treatment box. Is there services, mental health, survivorship clinics, et cetera? What do you think is required?
Maybe I can start with that. Obviously, everything you mentioned was like yes, but and I think others can comment a bit more on that. I mean, certainly mental health services. I think that's again something that the pandemic has kind of highlighted as well. I would say separate from COVID for cancer care, I think healthcare navigation services for patients. So, and I'm not just talking about how to access drugs. We think of the navigator sometimes in our world, and we think it's drug access, but it's such a complicated system that if there was a cancer navigator that could help patients and families say, look, this is what to expect. This is what's going to happen. These are the questions you should ask if someone doesn't tell you, that can kind of shepherd them through that process. That's not necessarily embedded within like the oncologist team. I think that would be huge. And obviously that's something that could speak to, even as patients approach palliative care, end of life, some guidance on how to navigate that. And maybe that's a network of patients who have gone through the system before, or family members who've helped, loved ones go through that system. I don't know how that works, but I think that would be on my wish list.
Thank you, Charlene.
I agree with that. And it's really a bridge to, I think that I was thinking exactly the same thing. We have a few primarily nurse-led navigation teams through, particularly in the GI world, through multidisciplinary care. But it's not just about care, right? They're the folks who are getting them involved with nutrition, psychosocial services, palliative care if appropriate, getting them on a survivorship path when that's appropriate. That I think all of us would love to do, but don't have the time. And I think the folks who are doing it cannot, and not only that, reduce some of the system elements that we're talking about, redundancy of visits, wasted time, right? So I would say that in terms of being able to facilitate care, enhance access to all the different supportive care issues, a vibrant investment in a vibrant navigation system is really, it would be really important.
Yeah, thank you. Ron.
I can't argue with any of those. I think those are extremely important issues, and I think we all would love to have something like that. I think survivorship is probably a big one. I know Princess Margaret does have a survivorship referral program, but you have to be a patient at Princess Margaret to be able to access it. And if you're not, you can't access it. So I think something coming from the provincial level that can be developed that we all have access to, or resources put in that we can all develop a program like that. I think we're all seeing younger and younger patients, and I think there's a huge issue of survivorship for that group of patients. We're seeing younger people where fertility is an issue, and I think that's something a lot of us tend to forget about in an acute situation. But accessing people who can deal with this in a timely fashion, because we want to get on with therapy, but we also want to preserve fertility. And the fact that we're starting to see a lot of younger patients,
very interesting.
It's something that's an area that's extremely important to them.
Thank you. Brandon?
I couldn't agree with all of those anymore. They're all great resources for cancer patients. I really like the idea of a concierge to help patients navigate the system, and not just for cancer, but for any complex disease. It's very daunting, and we're not always the best at telling our patients where to go next. One program that we saw get a bit of a boost from the pandemic, which is in my world is really nice, is liquid biopsy. So that's a tool we can use to tell a patient's genetics without necessarily subjecting them to an interventional radiology procedure, which keeps them out of hospital, which is very nice. But again, it's one of many different programs, including the mental health, the survivorship, fertility. All of these are resources, and the more the better to help us treat our patients.
Thank you. Vincent.
I echo what others have said. In Alberta, when I moved here, there is a team called Transition Services, which I think taps into what Charlene and Scott and Ron have, and all others have said, but they really cater to those transition points at key, I guess, phases of a person's care. So once a person stops chemotherapy and goes on to see the GP, or once someone stops chemotherapy and goes on to end of life care, oftentimes patients get lost in those transition points. And I at least personally, I find that that's gotten worse during COVID. So I think further investment in that kind of area will be really helpful, because I think patients get really confused and lost during those time points. So I think something's to be said in terms of improving that part of their care.
Yeah, thank you so much. I'm going to just bridge that question into, and what does the oncology community need from a support perspective to stay vibrant, to be resilient? We talked about certainly wellness, mental health style programs, but is there other things that are more physical from an investment perspective that's required to ensure the vibrancy of the oncology community?
One of the things that we learned, and I think was presented at ESMO again this year, was this whole issue of burnout and resilience, and how there's been a significant detriment during this pandemic. And one of the things I've been pushing for many years now is, and one thing we don't have, when someone goes on vacation, when someone goes on sabbatical, as they can do a lot more frequently in the BCCA than we can here in Ontario, is the person who's left behind is covering. And we're all working to the max right now. And one of the things I've been pushing with our chiefs, I've gone through 2 chiefs now, and that is that we should have a cohort of individuals that want to semi-retire, but don't want to completely leave the oncology world and looking after patients. That there should be individuals who can fly in and cover maternity leaves, paternity leaves, medical leaves, and we don't have that. Ontario has an APP now. There's no reason that APP can't develop some type of funding for a group of individuals who don't want to work full-time anymore, but are there to be called upon to come in and cover people's practices. One of the things in the pandemic, I'm sure I'm no different than anybody else. I was away for 3 weeks this summer. That was the first day I took off in a year and a half. I had not had a day off since March 13th of 2020, or March 1st of 2020. So that's not going to work. That's why people burn out. And I'm sure all of us have had the same thing. We haven't had time off. It's been very difficult to have any time off. And when you try and have time off, you say, who's going to cover my practice? So I think that's one area that I think could be easily remedied, to allow people to have more time with family, and just get away from the everyday thing. The other thing, and we've been talking about this in our division now, is how can we limit emails after 6 o'clock at night and on weekends? I think all of us are basically available 24/7. And that has to be fixed. I think that has to change. And how do we change it? That's a good question. We've made proposals from our wellness committee, but there's got to be buy-in from everybody.
Corporations have dealt with that for sure. And they just said they put policies in place, period. Your world is, I think, a little different, but yes. Thank you. Did I hear there was a mentorship program one of you was running? Did I hear that correctly? Yes.
Me.
Yes. Mentorship programs.
Yeah.
I think, I think I also would say that, we've talked physician, medical, healthcare worker, wellness, and burnout. These are not new issues either. But I think it takes a culture shift. Like, it's thinking about organizational wellness. And so, Tate Shanafelt is someone who I trained with many, many years ago when I was a fellow at Mayo, and he's an oncologist. He's a hematologist oncologist, but he really went on to become very well known for the research he did in physician wellness and burnout. And so he's now a chief wellness officer at Stanford. And so, that's what we need. We need chief wellness officers in our healthcare institutions that are also mindfully thinking strategically about how do we make sure that we have a healthy, resilient workforce, not because it's soft and mushy, but because it sustains the healthcare system, right? And and so I think that that's something that in healthcare, especially, there's kind of like people are like, I've never, I work all the time. It's almost been a badge of honor when we try, but it's not sustainable.
I like to say, Charlene, oncologists are people too.
You know what, Charlene, that's amazing though, to hear about a chief wellness officer.
Yeah.
In particular, what it says about the organization, right? Because so often the wellness is, Ron, I'm sure you do a great job as the division wellness, but it's just a division wellness leader, but that's just one more job for you, right? As opposed to, first of all, the organizations, we take this seriously, and it's their full-time job to do this. That's amazing. Yeah, wow.
Yeah. Is there any final comments that people would like to make before we say good evening to each other? That this is available, that if you go, oh, I wish I had said, you can simply email Maria, who invited you to this session. That's always available. Colorectal cancer is one of the most open environments to hearing everyone's feedback. On behalf of that organization, thank you so much for your time this evening. It's always a pleasure, a great pleasure for me to speak with people like you. You are indeed heroes. Again, thank you for your time.
Thank
Great
you.
to see everybody.
Night, everybody.
Bye.
See you.
Thanks.
Stay well.
Yeah, take care. Bye-bye.
Bye-bye.
Bye.